webinar covering the topic of neurological impact of COVID-19 and how EEG is a help in assessing patients. I'd now like to introduce our presenter, Dr. Dona Murphey, who is the Director of Scientific Affairs at CortiCare, where she's involved with our EEG reading panel, as well as directly involved with our clinical trials division. And she had her training as an epileptologist, was board certified in clinical neurophysiology through her training at Baylor College of Medicine in Houston. And she's been actively involved in tracking the neurological impact of the pandemic. And particularly interesting here is that she succumbed to COVID-19 herself and has had a long recovery road. And it really, I think, brings home the impact of the neurological effects of this infection. So without any further ado, I will bring in Dr. Murphey at this point in time. So Dr. Murphey, you can turn on your camera. There you are. And we'll maximize you.
Thank you very much. And I'm going to pull my slide up here. I'll go ahead and start the presentation. So today I would like to discuss with everyone who has joined us the neurological, neurophysiological, more specifically manifestations of COVID. And we will be focusing on CNS manifestations and not peripheral nervous system manifestations, as we are trying to focus our efforts today around what happens with COVID patients on EEG. So this is just a preview of what we will be covering in a couple of statements here. Understanding the pathophysiology of COVID helps us to understand the symptoms that we see in our patients. Understanding the symptoms helps us to select the appropriate diagnostics, and understanding the diagnostics helps us to maximize the utility of those diagnostics, to reduce overutilization, and also to mitigate risk. When we know that there is significant risk, of course, when you order something that requires human beings to be around other human beings who could potentially disseminate this disease. So first, I wanted to provide just a little bit of background on kind of the neuroscientific underpinnings of SARS-CoV-2, which is the virus that causes COVID. What we know is that this virus comes from a family of viruses that has shown itself to be neuroinvasive, and that is no different for SARS-CoV-2. There is now increasing evidence that it, in fact, does infect neurons, and that there is transsynaptic transfer of the virus between neurons. We think that it may come through the olfactory nerve, because the olfactory or the nasal epithelium is particularly enriched in this receptor ACE2, which is a receptor for SARS-CoV-2. And so we think what happens is that virus attaches itself to the nasal epithelium and then invades the CNS through the olfactory nerve. There is a spike protein that is on that SARS-CoV-2 that is actually the receptor is working to receive that spike protein on the virus, and then also in conjunction with a priming protein called TMPRSS2. We think those things are really critical in enabling the transmission of this virus, or the infection of our nervous system ultimately with this virus. Indirectly, we think also, and I think this is a bit more theoretical in the CNS, that there is dysregulation of immune responses that may also contribute to neurological manifestations of COVID-19. We probably won't be talking as much about that, but I did want to mention it because I think a lot of people surmise that might be a contributing factor as well. Direct endothelial invasion has also been hypothesized. So like the vascular lining, right, of the blood vessels in the brain, theoretically, you could get breakdown of the blood-brain barrier, which may happen in infection of any kind, and have invasion through that route. It doesn't appear to happen in some like pretty compelling basic science studies where they've looked at human brain organoids, and they've looked at also mouse models and human postmortem tissue, brain tissue. So we don't think that it gets into the nervous system that in that method, through that method so much. But there has been at least one case report in which the virus was actually isolated in frontal lobe capillary endothelia. So it is possible that that is one way, but maybe perhaps not the predominant way in which we get this virus in our brains. What does appear to be true in those various models that I mentioned is that there is vascular remodeling in the brain at a microscopic level that is thought to be pathologic. So radially oriented blood vessels actually change their orientation, and that is thought to be potentially contributing to the pathology that we see in the CNS. Then also there is a possibility, as we see in other organ systems with COVID-19, and this is corroborated by animal and human postmortem studies, that endothelial damage happens, and you have thromboinflammation that causes microinfarcts. This again, in those models that I mentioned, which were like the human brain organoids and the mouse models, and in some human postmortem studies, this is not actually observed in brain tissue. So again, the thought is that maybe there is something that is happening with the change of the orientation of the blood vessels that is causing problems, if it has to do with the vascular system at all. And then finally, you can have, again, with the breakdown of the blood-brain barrier, leukocyte invasion. That's another postulated mechanism of injury and symptoms in COVID-19. There's really no evidence to that end. The couple of great reviews that were done in JAMA Neurology and also in Nature Medicine, I believe, in July and August. And I have all of the links, by the way, here in this presentation. They do not have evidence that actually bears this out, but it is, again, something that is suggested as a possible mechanism of injury in the brain. What we actually do see, and again, in those models that I mentioned, is that there is minimal immune cell infiltrate noted in patients who died with COVID-19. So yeah, again, we don't think if it is contributing that it's contributing heavily to what is happening. There's also in studies, transcriptional studies, there's no upregulation of type 1 interferon pathways either, which is just more evidence that this is probably, the harm that's caused in the CNS is probably not, it's probably not done by this mechanism, at least not predominantly. So here I talk about the effects of ACE2 receptor expression in the CNS. So where can this virus attach itself specifically in the brain? And there are specific areas that have enrichment in ACE2 receptor expression. So you can see a number of those areas are cortical areas, right? And then other areas are kind of deeper brain structures that could be reflected in cortical recordings. So this is why I kind of share with you the theoretical underpinnings here, or the neuroscientific underpinnings of this disease, because then it can help us to frame where we might be looking for effects at the, at a gross level when we're measuring with EEG, for instance. So here are some of the symptoms that people report with acute COVID infection. And this is both hospitalized patients and also patients who are not sick enough to be hospitalized. Headache and myalgia or fatigue occur in about 10 to 40% of hospitalized patients. It's theorized that this is a nonspecific inflammatory effect from macrophage release of CNS manifestations of this disease. In mildly symptomatic outpatients, nearly 70% reported fatigue, and anosmia and ageusia were also very commonly reported, occurring in about 65% of 202 patients surveyed in one study. There's actually interestingly, a differential with nearly 3/4 of women reporting altered sense of smell and taste, while only 55% of men actually reported these symptoms. None of these common clinical manifestations of COVID, in none of these do we actually typically observe any neural correlates on the EEG. Impairment of consciousness manifested in nearly 40% of patients. And this could be due to stroke, to encephalitis, to seizure, demyelinating disease, or toxic metabolic encephalopathies in COVID, which do typically manifest on the EEG, albeit perhaps not specifically. So can COVID cause seizures? And this is something that we are principally using EEG to measure. So it's an important question. Theoretically, COVID can cause new onset focal seizures. It can cause focal injury in the brain. It can also exacerbate underlying epilepsy, theoretically. But actually, the studies that have been done in populations of people who have chronic epilepsy do not suggest that they are actually at increased risk. But we know that, again, theoretically, in somebody who has fever and infection happening in their bodies anywhere, can have elevated risk of seizures, recrudescence if they are well controlled, or worsening otherwise if they're already poorly controlled. And yeah, so I think that's probably most of what I wanted to share there. And then we know also that COVID causes severe illness in 22% of patients who are hospitalized, whereas ICU care is really only necessitated in about 5% of those hospitalized patients who are non-COVID patients. So this substantially increases the risk that you have severe illness, right, requiring critical care. This is the context in which we do become concerned about seizures. And this happens, when you have somebody who is septic, when they are critically ill, we do have increased incidence of especially non-convulsive events, cerebral events. So that, I think, is the take-home point of this slide. The CDC actually, the CDC on November 2nd actually updated their list of illnesses that put people at known increased risk for severe COVID. And so these are the conditions where you want to have, maybe perhaps lower suspicion that these people may be seizing if they are altered in the ICU or otherwise in the hospital. So this is just pulling from data that we've had for many years now. The ACNS had a series of papers on guidelines for continuous EEG monitoring in critically ill patients. This was in 2015. So these are the percentages of adults and children who manifest seizures, non-convulsive seizures specifically, on continuous EEG monitoring in these different etiologies. So you can see any of these things are possible in COVID. They're not, I should emphasize that they're not common in COVID, right? But they do happen, right? COVID itself can be neuroinvasive. So you get CNS infections, you get encephalitides, you get sepsis in COVID, you can have strokes in COVID, you can have hypoxic injury in COVID because it's a respiratory disease. So any of these things are possible, and so we do have to be thinking about seizures in the critically ill. There was a neat paper in Seizure in October. The next few slides are actually about that paper. And this is where we talk specifically about the ways in which COVID can manifest on EEG. So here you can see, this is a study of 617 patients. It's reported across 84 selected retrospective studies that were reviewed. And notably, some of these studies, or many of these studies, were they were peer reviewed, but they were also from BioXRV, MedXRV. These are not yet peer reviewed. They're preprint publications. So this is something to bear in mind. But because this is a rapidly evolving science, it would have been very incomplete to exclude those studies. So I think the appropriate thing was done here, and that was to include them. And here in the first slide, you can see that the most common, by far, abnormality that you see on EEG and COVID is a non-specific diffuse slowing of the background. But in a smaller percentage of cases, you do see focal slowing. And again, that could be because you have focal injury that does occur in COVID. Sometimes you may see that actually in the absence of identifiable injury on CT or MRI. And then, the other abnormalities are far fewer, I think, in prevalence. But there you have the distribution of where you find those abnormalities on EEG. The next slide is about the periodic and rhythmic patterns that you see on EEG in COVID. And here you can see that the most commonly reported abnormality would be generalized periodic discharges. But also, generalized rhythmic delta activity is pretty common here too. So again, this shows you kind of the relative prevalence of all of those different findings per the ACNS guidelines on how we classify the periodic patterns of critical illness. The next slide shows distinctly epileptiform abnormalities, including focal epileptiform discharges, multifocal epileptiform discharges, generalized discharges, seizures, and status epilepticus. And this is not an insignificant number of people who are manifesting with these kinds of discrete epileptiform abnormalities. So it's something definitely to keep in mind. In this study, actually, I think it was about 30%. I might show it on a future slide. I'll mention it here though. About 30% of the studies that they reviewed were using continuous EEG monitoring, and then the vast majority of remaining studies were routine. There were a few that were, I think, like 8-channel reduced montage rapid EEG. So that is something to keep in mind. Your ability to pick up these abnormalities, of course, is going to be enhanced by increasing the period of time over which you monitor. But this is something that is a trade-off in COVID, right? Because that potentially will extend the risk of people who were involved in that monitoring process. So so the next slide is the final slide from this particular paper, and it is about the EEG abnormalities and how they manifest regionally in the brain. So half of the abnormalities they found were actually coming from the frontal region. I don't have that on the slide, but yeah, I mean, you can see that here in the graph. And then there were also, I should also explain the graph because I had to move the labels to the side. So on the very left, the orange and the blue, or the blue and the orange, are slowing. And then the next column is actually LPDs, or lateralized periodic discharges, or multifocal periodic discharges. And the subsequent column is LRDA and multifocal RDA. And then the next column is epileptiform discharges, seizures, and status epilepticus. So this again is taken from this paper in Seizure in October. And you can see, again, like the most common thing is slowing, right? And the most common region in which that is manifest is actually frontal. And for these other abnormalities as well, a substantial amount of those findings are actually frontal findings. So the next slide shows that or kind of summarizes that EEG findings are very common in COVID, and that they're most commonly ordered for altered mental status or encephalopathy. As we have discussed now, the most common finding is diffuse slowing, most commonly found in the frontal lobe. And then it's important to note that 13% of the patients here in the studies that they examined, again, 84 different studies with 617 patients, demonstrated epileptiform discharges on their studies. And 5% of patients were actually in status epilepticus. And that is not insignificant. So it's reason for really considering at least a routine, if not a continuous EEG study in patients who have COVID and who are altered or who are having episodic behavioral changes. So here, I just wanted to make the point on the next slide that continuous EEG monitoring has higher sensitivity, I mean, as you might surmise, than routine EEG, just because we're doing it over a greater period of time, right? Yeah, I think I covered actually some of what I share here. And then the final point that I just wanted to make is that these abnormalities don't vanish after people are discharged from the hospital or after the acute period of infection. a very significant percentage, I think 30 to 40% at the very least, it depends on the study, of people who have been infected with COVID acutely, whether requiring hospitalization or not, end up reporting cognitive symptoms, sometimes episodic cognitive symptoms. And this also might be rationale for ordering EEGs on patients in the outpatient setting. So this is actually a New York Times piece that was done, and I was interviewed for this because I myself had cognitive manifestations of COVID. They were fairly mild, I think, relative to some of the cases that I have heard. But I think it's important to mention because, this shouldn't fall off our radar to actually use EEG potentially in our diagnostic workup of patients who continue to have cognitive or other CNS manifestations of this disease, sometimes even many, many months after initial infection. And then finally, I just wanted to leave us with this kind of word of caution. Again, as I alluded to at the very beginning of this talk, it's important to recognize that, this is a highly transmissible disease, and we don't want to unnecessarily order EEGs. And for the continuous studies that we are able to order in the context where we have those resources, we don't want to use them gratuitously. So we want to be very targeted in who we order those studies for. And I think the ACNS guidelines actually provide a really great template for who should get those studies. I don't think it's different in COVID. And we want to be very judicious about how long we order the studies to go. Because again, we're just extending people's risk who are involved in the diagnostic workup of these patients when we run studies for a long time that require, techs to go in continually to fix electrodes and whatnot. And then finally, in the outpatient environment, do think about ambulatory EEG or routine EEG done on COVID patients who continue to have central nervous system manifestations of this disease. So I'm going to stop there and give people an opportunity to actually ask any questions they may have.
So we have a couple of questions here. One is, are these patients in these studies patients who had previously no form of epilepsy?
It depends on the studies. So some studies were actually, like the one, I think the one that I may have linked to in this presentation was a study of a couple hundred patients, and they were specifically epilepsy patients to examine the risk of exacerbating the epilepsy that they already had underlying. But these other studies, I think this was maybe some of these were some of the caveats that were outlined in that seizure paper from October. They did not necessarily all state explicitly whether they inquired about that history of epilepsy or of prior seizure. So that is, definitely kind of something to keep in mind. And we should be consuming these, consuming these resources with at least a grain of salt, because they are not all peer reviewed. But yeah. Thank you very much for the question. It is a very relevant one.
Another question is, have we seen any correlation between the type and severity of symptoms and the EEG findings?
That's a good question. I haven't seen actually any papers attempt to correlate those things. I imagine what the question that is being asked is like, is there any specificity, for instance, like generalized periodic discharges at like 3 hertz correlates with, a particular clinical picture. I can imagine what that clinical picture would be, and it would be one that is pretty dire. But I don't think anybody has looked at that explicitly yet.
And the exacerbations that were shown, were they due specifically to COVID?
I guess I'm not sure. Maybe we're talking about seizure exacerbations in epilepsy patients. I'm not sure what that is in reference to.
Right.
Yeah, it's that's going to be hard to pinpoint. This is all like correlational data, right? So I think all they can report is that it was temporally possibility that it was related. But yeah, I think even as clinicians, when we have epilepsy patients who are reporting increased seizure frequency, it could be any number of things reported or unreported that are actually causal. And we can only operate off of assumptions that we make on correlational data. I think that's all we have here, unfortunately, as well.